Welcome, everybody. I'm excited to be here and talk about a technology to me that is just freaking exciting. I love it. It's far more than really an impression replacement. People think digital scanning just replaces traditional impressions, and we're going to get really heavily into it. I'm sponsored by Align. It's my disclaimer. Happy to answer questions the best I can at the end of the night. So when I look at what I've been using for years and years in wonderful products, absolutely, from Empergum, Aquasil, Panasil, just great products. But I just don't see this as the future of dentistry. And I think that digital scanning is far more than this. I really, really do. I've been using digital scanning for over 5 years. I've worked with two systems, TrueDef and iTero. And so it's hard if people have questions about other systems because these are the two I've used. I will say these systems, and obviously tonight I'll be talking more about iTero. It's just getting so much easier and faster, just so much. And it's really just so much more than capturing an impression. And there's no doubt iTero and Align created an incredible dynamic with ClinCheck Pro. For our Invisalign patients. But tonight is really about expanding the advantages of digital imaging for the general practitioner. And that's really what I want to get into. I'll walk you through about a 40-minute tour, 40 to 45-minute tour, and then I'll be happy to answer questions to the best that I can. First off, let me just say that if anybody out there thinks they're perfect, I know I'm not. And to me, it's all about, can we correct our errors? Such that, for example, under preparation. What do you do when you under prepare? And labs will tell you we under prepare occlusal clearance. You'd think we know what 1 and 2 millimeter clearance is, and oftentimes we just can't see back there. And we're going to show you how we correct these problems. Improper marginal preparation. You're going to be able to see, I'll show you scans that really, if you can't see the final result, then before you send it to the lab, it's so much easier to see than looking at an impression. And then they have eraser tools and occlusalgrams, and these help you allow to really make the changes that you're looking for. And then we get into really cool things like multi-bite scans, and this really enables you as the practitioner to transfer opening vertical dimensions or maintaining vertical dimensions when you're transferring information, like someone's night guard, you finally got them there, and you don't want to open the vertical. But if you just send traditional impressions, how are you going to maintain that vertical? We'll talk about a multi-bite case tonight. And digital creates a far more pleasant patient experience. And it's not just the goop, but you can really scan at a pace that makes it much less stressful, both for you and the patient. We'll talk about a case tonight. And I can go on and on about these advantages for indirect dentistry beyond the goop. And I'm not anti-goop. I just think our patients are so much more appreciative with these advancements in technology. And tonight I really want to get into, how does digital really get involved in diagnostics, documentation, visualization, and communication? How do we use this in our initial exams and our recall exams? How does this help grow your practice? Because ultimately, why do you invest in the technology? Yes, to make your patients have a better outcome, a better experience, but you really want to grow your practice and create the value. And I'm going to even show you what we're doing with that in our own dental plan tonight. So our first case, it's a broken upper zirconia bridge. Like none of you have seen these. It's less than 2 years old, and it's on an 82-year-old healthy patient. I see routinely patients that I would call adults. I do have a large amount of patients over the age of 70 and 80. Drove a patient home yesterday who was 97 after we made her an anterior immediate temporary bridge at 97. But let's focus on James, an 82-year-old healthy with a 2-year-old broken zirconia bridge. So the first thing we did, and it's not even me, he comes in, he's got a broken bridge, my assistant will scan him. All my assistants know how to do this. They all love to do it. It's really like a video game. My assistants can scan a full arch in about 2 to 3 minutes maximum, maximum. That's how much faster these have been getting. No powdering, none of that. And it's really about understanding, letting the patient understand the issues. So the visual tool alone, when I can show them there's decay underneath the anterior abutment, and then I can just show full arch occlusion. And the fact that I've got really short teeth here and really limited occlusal clearance that you'll see. So here's, for example, an occlusal clearance scale. And in yellow on the molar, you will see that we have really, in the red area, only 2/10 clearance. So when this bridge was made and adjusted, the dentist only had 2/10 clearance for the zirconia and basically 2/10 to 4/10 on the bicuspid. Well, the fact is, on a molar, you're going to need a millimeter clearance for zirconia. That's the fact. Probably a millimeter is suitable. Millimeter is fine in the bicuspid region, but 2/10 of a millimeter is absolutely going to be failure, and you're going to see the failure in the connector zone, and that's all been shown in the literature. So this bridge was totally underprepared, only 2 years old, an expensive failure for this patient. Glad it wasn't mine. So with the scanning, I can, show the patient the opposing arch, look at the opposing arch, and see that I've got a gold crown that I actually did on number 32 because I had to replace a fractured zirconia crown that was underprepared. And there's an older pre-existing number 30 PFM. So now we're looking at the opposing arch on the occlusogram. This is where digital's amazing. If you had to adjust, it will tell you where to adjust beyond articulating paper. And you all know you can put your Vaseline on articulating paper and hopefully you'll get some marks on zirconia or gold. This tells you exactly where to adjust if you wanted to. Just showing you both teeth where you could adjust. In color mode, which is what I really prefer because the patient sees this, the patient can understand the issues of short teeth, limited clearance. What am I going to do? Am I going to make another bridge? These short heights, can these really hold a bridge of this dimension? So if the patient wants a bridge, what are we going to do? So with all of this, I can explain to the patient that we can do a couple different things. We could do crowns and an implant. We're going to have to do a sinus lift with some periodontal surgery. And then we have more guided tooth preparation because I have iTero and the occlusogram. I could make a 3-unit bridge, but he's going to need perio surgery because I need to make these teeth longer. And I would have guided tooth, again, preparation. Or I could make them 2 single crowns with a laser gingivectomy and, again, guided tooth preparation. Again, so important to have digital. So I'll take these patients and I'll actually explain. Against your gold tooth and that tooth, and we're all good. No surgery. And the truth is when I videotape this, it's really just as an educational tool. And it becomes so powerful to the patients to understand because he didn't want an implant. He didn't want sinus surgery. He didn't want crown length fitting. He didn't want to go through a surgical procedure, and he didn't want to have the potential failure of the bridge again. The Ponic wasn't going to add chewing function, so he really wasn't into that. So we compromised, and compromise is not a negative. We did a laser gingivectomy, and we had plenty of tissue. So he elected to have the gingivectomies done, and with tooth number 2 having limited room, he opted for, again, a gold crown to way back, and I could clear basically about a 0.5 millimeter to create reduction. That's what I had to do, create a 0.5 millimeter occlusal clearance. 1 millimeter was not going to happen. 1 millimeter was only going to happen on tooth number 4. So what do? You take all this wonderful guidance, you probe the tissue. I got plenty of attached gingival tissue, and I'm going to just basically do a gingivectomy with an activated diode tip. CO2 laser would have been fine. Many of you have different lasers. That's what I'm going to do. Yeah, the tissue looks kind of beat up, but that's what it looks like after you do a diode gingivectomy. It'll be fine. It heals beautifully. This is with the Picasso light. Now, I have immediately about another 2.5 millimeters of room for retention. Then I can create the occlusal clearance, and I have at least enough occlusal clearance of 1 millimeter, and now retentive preparation. So here, again, I'm using the iTero as a diagnostic tool. I'm just probing him because he's numb, showing you the excess tissue. So he's got 5 millimeters here. We could have done crown lengthening, opened the room up for the interproximal or interdental connectors. He didn't want it. So now we get into the precision of retraction. So 2 weeks later, he comes in after we attempt him. And this is how I do it. Now you can do a laser troughing, which I have no problem with. In this case, I'm using a double cord technique. 000 first, a little viscostat clear over my 000 cord. And then my second cord is either a number 1 or a number 2 cord. I use the systems from Ultradent or Premier. I love their knitted cords. The key is you have to see 360 degrees around your cord, around the margin. So here's a number 2 cord that I can see that I've laterally displaced the tissue over my 000, over my viscostat. Here, I've got a number 1 cord over my 000, and I actually placed another cord, so they've got 3 cords. So I needed 3 cords here to push this tissue out of the way. Obviously, you could have used a laser, no doubt. Then I have the patient bite down for 5 minutes on these Traxident caps from Premier. I always let my retraction cord sit 5 minutes. And the beauty of digital scanning is you can do 1 tooth at a time. You don't have to pull all the cords at one time and inject the goop. You just do digital scanning 1 at a time. So what you can see is I highlight, and this is with iTero. You highlight the preparation, and then you're just going to start scanning. And as you scan, and then once you're done, all you do is you move this little green button over the 1 tooth you just scanned. You pull the cord, you scan it, and now you save it. So you love your image, you can see it, and then you move on to the next tooth. So now I'm going to hit the next tooth, pull the cord, and go 1 tooth at a time. That's the beauty. And the beauty is it's the simplicity. If the patient needs to spit, swallow, it doesn't matter. There's no rush. You can leave the second cord in until you're ready to scan the next tooth, 1 tooth at a time. So this is what you really see when it pops up. This is double cord retraction. And you can really see the power of retraction here in digital imaging. And you know you capture your margins. If not, again, the digital technology will show you this, and you go back, re-prepare, and repack your tissue. But the beauty is you would know instantly. You don't have to wait 5 minutes to pull it out of the mouth. It's that fast. You scan, let it process, and you know within literally 30 to 40 seconds. So here's my occlusal clearance. So by lengthening the teeth, by lengthening the bicuspid, I was able then to prepare the bicuspid and have enough occlusal clearance, and the same was for the molar. So let's just talk about occlusal clearance. Let's say you wanted to correct the occlusal clearance. Let's say all of a sudden you prepped the tooth and now you realize, oh, I under-prepped it. Well, it's really not that big a deal. All you do with iTero is, and other systems, you would go into their prep mode, you'd hit the preparation itself, and then you would just hit the eraser tool. And the eraser tool allows you to circle the area while the tooth is in its buccal view. You circle it, and it erases it. And after the eraser area, all you're then going to do is scan the occlusal area. You don't have to pack cord or anything else. It'll just, you go right back into the abutment, and you just rescan. And I got to tell you, it's just a great tool versus your lab telling you underprepared. They send you a Duralay jig, and you hopefully can get it to fit. And this is where digital technologies are amazing. And now once you're done, you just move your green dot over the tooth, hit save, and you're off to the races. Because as soon as you hit that green dot and you go scanning the arch, that tooth is saved, that preparation is saved. So now, when you look at it, you go to your occlusogram, and your occlusogram will allow you to see exactly if you've underprepared, where you're underprepared, and you can go back. It's just such a beautiful thing. So in this case, I have approximately 1 millimeter of occlusal clearance on number 4, which is fine for zirconia. And then on the posterior tooth, I really only had a 0.5 millimeter. That's it. So we had discussed doing gold for the molar and an aesthetic zirconia for the bicuspid. And you can see as occlusion, yes, the lower molar would have had a little bit more chewing function, but that really wasn't what he was interested in. These are the 3D models. There's your gold crown on the 3D model. And the final restorations, really, I'm looking for long-term function. So the posterior tooth was cemented with Theracem. The anterior zirconia crown I cemented with Ceramur. And this is a key point that I really would love to bring out tonight. My cements are usually bioactive cements. And I would tell you, most of my geriatric margins are subgingival. And as a result, I don't want to use a resin-only cement because I don't think we're getting great isolation based on the gingival crevicular fluid. So the cements I use today are Theracem, Ceramur, and Activa cement. And I just got to tell you, to me, if you have calcium-releasing cements that can potentially remineralize at the margins, this is what we should all be thinking about. And I pick each cement based on retention. Theracem will have more retention than Ceramur. Ceramur will have more calcium release than Theracem. But again, I'm really trying to pick what's best for my patients. So in this case, digital scanning was essential. It was essential in explaining the issues, understanding where to selectively prepare the tooth, and equally important, a superior tool to enhance better decision making. Now, in the past, I would take a bunch of pictures, maybe take some impressions, pour up the models, use my digital photography, and try to explain it to the patient. What happens now is my team does all this. I walk in a room, and it's show and tell. Absolutely remarkable. Case 2 is Sydney. And this is really where we're going with all this digital imaging, how time-lapse opportunities really add more to digital imaging. So Sydney's a 70-year-old executive trainer. You'd think she was 53, and she is 70. She just had aorta valve replacement. She's got bleeding on probing in all 4 quadrants, with isolated 5 to 7 millimeter pockets. So a couple lower molar pockets. She's had multiple surgeries. She power brushes and flosses, and she's frustrated. Her cardiologist said to her, periodontal problems. Do you have any? And she goes, well, I'm dealing with all these issues, and I'm doing the best I can. So she came back to me and said she needed to ensure minimal inflammation based on her cardiologist. She denies clenching or grinding, which I'll show you as a joke, won't wear an appliance at night. And I've redone much of her posterior dentistry because she had kept chipping old PFMs that were done 10 and 20 years previously. So here's her perio charting, and you can see about 8 areas bleeding here, another 15 up here, another 15 down here, another 10 here. I mean, she's got 40, 50 bleeding points. She's got huge tori and Haight's impressions. Her lower molars were the areas with 7s. And what are you going to do for her? She didn't want to have more surgery. She just didn't. So we scanned her. And I'll show you what we did. So this is the basic model view in iTero. And from there, you can open up many different colored templates from the model view. So here's just maxillary and mandibular in color mode. See some lower anterior shifting, typical. And what I will show you even more, I had to explain her chipped teeth. Look at the wear. Look at the chips. Now, she denies grinding, and all I would say to her is, do you really think you were born with this wear? So I have to try to explain the wear patterns to her, and there's nothing better than explaining it in this kind of technology, because it's sitting there on a screen right in front of her. And when you show her all these wear patterns, she starts to understand even more about her chipped teeth. So this is what's interesting where iTero is going. So what we do now with our patients is we actually do time-lapse. Here, there's about 11 months difference between when you image a patient and then you image them, and here are 11 months later. And we can show them recession. This is where you were, this is where you have recession. And a lot of times your patients will ask you, are my teeth moving? And you go, it's hard for you to remember. So minor tooth movements, are they wearing their retainers? Has the occlusion shifted? Has the occlusion then caused a problem? And now all of a sudden we get to do all these really cool things with time-lapse. We get to occlusal wear, like in Sydney's case. So we'll take scans that again are 11 months apart and take a look at the distolingual of a lower number 31. If we can start to understand these technologies and then compare what it looked like a year or 2 years later, now you can understand not just bruxism, but occlusion in itself. How can we avoid cracked teeth? How do we do adjustments? How do we safeguard this occlusal wear? All of this leads to far more enhanced discussion and productivity in my office. All of this does. Back to Sydney. So you scan her. The lab would make 3D printed models. This is called PerioProtect, a system I absolutely believe in for my refractory cases where patients are doing everything they can and we can't get them better. But what's interesting is the lab will print the model, then they take an impression in their own environment, pour that up in stone, score the stone to create a gasket seal that will hold a 1.7% peroxide in place. So here's that seal. And that seal has been shown that if you put in a low dose peroxide, we call it periogel, it can go up to 9 millimeters within the pocket. So we are treating refractory disease and issues in conjunction with scaling and planing and lasers and all that in our practice. And this doesn't eliminate surgery, but boy, when you have periimplantitis issues or maintenance issues, PerioProtect has just become a home run in our practice. And in 3 years, we've done over 275 cases. It's just a home run. So worthwhile. And I love the combination of digital imaging with it. This is her try-in. Then we'll place the gel in for 10 minutes. She only wears the trays for 10 minutes a day, 15 minutes maximum. And they wear it in the shower. It just works amazing. And this is her first 10 minutes to health. So here's what's amazing. We made these trays for her, and she's on the road doing her thing. We got a call just last week. She lost her trays. She was panicking because she equates her periodontal issues to her heart condition and her aorta valve repair. The beautiful part with digital scanning, it's in the cloud. All we had to do is have some new models processed, and we just charge her fee, which is about $150 with all involved per tray. The system, we charge $400 per tray, and patients feel better, their mouth feels better, and I love the digital component with it. So in this case, digital scanning was again essential in explaining the issues of wear, and a technology that was effortless, and she absolutely hated taking impressions with her tori. With time-lapse imaging, we can offer these patients, we're going to do this complimentary in our university dental plan. This is our in-office, some people call it a club, we call it our prevention plan. And this is our prevention plan. And we give people 13% credit card discount, 15% discount on anything we do. It includes 2 cleanings a year, and if they need 4910s and far more work, the 2 cleanings are prorated into all that. We include Carry View and Spectra along with Bite Wings. This is all just part of the plan, no additional fees. Cone beams are 15% off. Perio Protect is 15% off. And a lot of these would be just denied by an insurance company. I have 2,000 active patients in my practice, and we are 4 short of hitting our 1,000th patient in our plan. They prepay, I got cash in the bank, all of this. So we're going to be doing time-lapse for our patients, and we're not going to charge for it. It'll be all part of our prevention plan. Why? Because it just makes us better diagnosticians, and equally, it's just going to grow our volume in our business. Absolutely will grow our volume. So this was case number 3. This is a multi-bite case. This is on one of my elderly patients. She's a disaster. And she had collapse, and I'll show you the collapse. That's her overbite. And we just had to rebuild her. So this is an implant healing abutment that was placed some time ago. Note the overbite. Look at where her overbite is. So the plan was to take a multi-bite record. So you take one of her traditional vertical, and then we're going to open her vertical. I'll show you how we do that. The plan was to make her an 8-unit temporary bridge. Ultimately, we were going to cantilever 5 and 12 in the temporary bridge. Then we were going to extract 10 and place implants 4, 10, and 12. So it was a complex perio implant case. And then we would establish whether we would even save 8, 9, and 11. So ultimately, she would have 4 implants in the upper jaw. In the pre-digital era, we would have taken a set of impressions, opened the vertical on an articulator. Now we can do that virtually. This is how cool this is. Okay, so here's the intraoral image. Let's blend the intraoral image into her mouth. That's the digital scan, overlaid. So here's her intraoral abutment. Now totally iteroed. That's bite 1. Notice 1. Then we'll put Futar from Kettenbach, great bite registration, and open her vertical. So here's the Futar. We're going to open her vertical. And when you scan, you just scan in the multi-bite number 2. The Futar disappears, and there's her new vertical. So now the lab, when they make her temporary bridge, is going to open her vertical to that, create the room, create my temporary bridge. So now we had the bite. Then you go into what we call the restorative. And this is what you're trained on. You go into the restorative mode. This is a scan body. And all I'm then going to do is I'm going to scan the scan body so they know the depth of the tissue, the orientation. This is what we do for our permanents. I scan her upper existing 4 crowns. They're going to prep them in the lab, put on an abutment for the number 6, and we're going to make her a temporary bridge. This is now 4 months later, 5 months later. Maybe 6 months. We've already uncovered now implants in 4, 10, and 12. And you can kind of see number 10 right here. So all I'm doing is relieving her temporary bridge I've already opened her 3 millimeters, and we're going to even open her more. So with multi-bite, we can open verticals with really amazing precision. The labs know exactly where you want to get to, and we're going to open her more in her final restorations. Love this, love it. So now we get to, okay, we've got some cool tools going on. What else can we do? So this is what I'm going to tell you. I'm 61. Never had more fun in my life than now. I got all these great things going on in my practice. I'm growing practice, multiple associates, multiple specialists. And really, these are changing times. You know, for the first for the first 20 years of my career, man, there was nothing changing. Composites, you know, maybe whatever, Emacs, but there was nothing really changing. Now technologies have really changed. So in dentistry, it really relates to creating more efficient diagnostics. And I say efficient because you'll see why. These efficient diagnostics result in better decision making and ultimately a higher quality of care. Take the guy's broken zirconia bridge, only in his mouth 2 years. His lower zirconia crown that broke after 1 year. $5,000 worth of failures based on poor diagnostic imaging, under preparation, lab making it for the doctor, and failure. Ultimately, with better diagnostics, this will lower the cost of the patient by creating a better treatment plan with better guidance and a higher chance of long-term success. That's where diagnostics become key. So my bottom line is, if I can lower the ultimate failure and create what I think is the best treatment plan, I think I'm going to lower the patient's cost. I want to do all these diagnostics in my office. That makes it far more efficient. And then I can deliver the quality of care we all want to do. So this is how I summarize diagnostics today. They can be customized to your office's focus, specific to each patient's requirements. And this is all to the betterment of our patients. In Explorer, 2D X-rays and impression materials do not do that. They don't even come close to doing customization of diagnostics. So really, what are modern day diagnostics and how do we create the value add? So the value add really today, I look at these as modern day diagnostics, digital X-rays, fluorescence. I use fluorescence all the time before I do sealants, before I prepare small fissures, allows me to see through the enamel, through smooth surface areas. I use transillumination like Carry View. This allows me to see interproximal lesions, cracks, craze lines, recurrent decay. Amazing technologies. Digital records and how I use iTero, which we'll get into, in cone beams. I would never buy a digital pan today. I think it's totally a waste of money. Cone beams are where we're all going, and cone beams will become the standard of care in diagnostics. There's no doubt about it. I don't know if we'll be taking full mouth series of X-rays in 2D anymore. It's just, cone beams are just so much better. So the initial exam, this is what I want to kind of conclude our night with. The initial exam, it's really implementing today's technologies to create the value add. So modern day technology, this is in my office, and I'll just take you through a little stroll. Advanced diagnostics and treatment plan acceptance. We're going to use what's appropriate. So here's your 2D X-rays. We scan every patient when they come in. And there's Carry View on her screen comparing Carry View to 2D X-rays. Here's my assistant. My assistants do all the scanning in the office for the initial exam. I'm working next door. They're scanning the new patient. That's what she wants to be doing. And she's going to be looking at the scan, making sure everything's there. Looking at the other imaging that's already in front of the patient, which is Spectra and Carry View. And that's what's there for advanced caries diagnostics. The assistants just have so much more going on then. They're explaining to the patient, involving the patient. So the patient, I'm not even in the room. Assistants are explaining all this. And it really gets into, why do I do this? Well, what percent of dentistry that is treatment plan is begun year one? So you sit there, you tell a patient they need this. What percent of that is actually begun in year one? So the patient, do they need an implant? Are they going to think it over? Are they going to do nothing, get a second opinion? The amount of dentistry that is begun in the first year after treatment plan is 22%. We are terrible communicators, the worst. And so it's awful. So I got to bring in a book, and it's called Give and Take. And I'm going to tell you, you have to stop selling. It's amazing how many dentists out there, and I'm not saying any of you, dentists just sell. They're just, patients come in, and I know what's going on in the real world, trust me, and people are just being sold. And what you really want to do is, in this book, is about people who are givers and people who are takers. It's the best book I've read in years. It's amazing. And the book basically says, when you walk into your dental patient, stop selling, start listening and asking questions. Takers tell patients what they want to do. In other words, takers will tell the patient what they want the patient to do. The book goes into matchers, offer a deal to get the work going. I'll do it for 20%, or I'll do 2 + 1. Givers ask the patient what they want. Sound simple? Most dentists don't do it. By asking the questions and getting to know their patients, givers build trust and gain knowledge about what their customers' needs are. And this is really what we call powerless communication, which is great, because the art of advocacy is to lead your patients to the conclusion on your terms. You want to guide them to what's best for them. And the true purpose of the initial exam should be to understand what the patient wants, then educate them and inform them. And this is so wonderfully done with advanced diagnostics. Sounds so simple. So here's how digital scanning and other things work together. Here's my new patient, Irma. She's 78, has high blood pressure, under control, anti-anxiety medication. She comes in with bleeding gums. She's had them for years, and she's starting to get dry mouth. She went to her last dentist, who she'd been seeing for a number of years. He said everything was fine. He did a prophy on her. She has sensitive teeth to ice cream, and she loves her ice cream. Her older sister lost her teeth recently, and she's worried that this may happen. So she came in for a second opinion to see me. So this is the old days. You take an FMX, you use your eyes, use an Explorer and a probe. And then there's your FMX. To me, it's all about creating a want and a need. So in this case, what I want to do is I want to provide information and creating a path of communication to involve the patient so they want their treatment. That's the key. You got to involve the patient. Don't just tell them. Don't just show them. Involve them. How do we involve them? I'll show you. So these are her x-rays. They mean nothing to her. Okay, yeah, you've got a lot of tartar underneath. This is where the tartar is. Here's some images of a root canal and a crown, and it's all 2D. Now imagine we've taken a scan on her. My assistant does this. This is her mouth. Now I can explain to her, for example, her front right tooth. It's yellow. It's a calcified canal. And now we get into what happened to this tooth 50 years previously. Here's the digital, here's my image taking my intraoral photography. And this is how beautiful digital scanning is. So now I can just show her everything on a digital scan and work her up. So one of the beautiful aspects is digital scanning is multifunctionality. In this case, we needed to treat her perio. So we took the same scans that we used to show the patient what was going on, and we sent those for the trays to be delivered, to be manufactured, and then we developed our own treatment plan for what was best for her. And so in my full day courses, I talk about how we take these impressions digitally. We deliver the trays 2 weeks later. The patients wear the trays for, I would say about 2 weeks. And then they start their active therapy with my hygienist, 2 or 3 visits. And the beautiful part is my office is busy. So when we see the patient at the initial exam and we know it's going to be 2 weeks for the trays to be delivered and 2 weeks more for the patient to wear them before they start their therapy, we can be booking their active therapy a month out, promoting our dental plan, and it all works so beautifully. We evaluate them 6 weeks later, and as I teach, we never probe for 3 to 6 months. And this is why we use these technologies. We don't want to have surprises. We know PerioProtect's going to bleach her teeth. We've got the imaging, and we tell her we're going to have to do a veneer on number 8. No doubt about it. If that's what we know, it will not bleach as well as the other teeth. I just don't want that mistake. In other words, I want to make sure I've explained everything to the patient. If 8 bleaches, perfect. And I don't have to do a veneer on the tooth, but I want her to understand what's going on. And these are kind of cool pictures from Shofu's camera called the Eye Special 2. This is their isolated shade mode. It takes out the pink. We use this for all our color mapping and color shading when we work with labs. My last case is Kobita. And again, that's why I need an hour for my initial exams. I look at my initial exams, and now cone beams have become like digital scanning, part of many of our initial exams, if appropriate. If appropriate. She's 72 years old, type 2 diabetes under control. So she's under control with her diabetes. She's got faint pain on the upper right, faint pain, and her lower left has now become sensitive to chewing. Her last visit was a year ago, and she had no symptoms and just had a routine cleaning, and the dentist said everything was fine. Her sister referred her to our practice, and she's worried about losing more teeth. So let's take a look at 2D imaging. 2D imaging. Here's your FMX. And she's got upper right sensitivity. Is it the root tip that I see, or is there something going on with a question mark of maybe a short fill, a number 3, or is that number 2? It's number 3. And what do we see? Not that much. You just don't see that much. And the root tip isn't causing a problem. That's embedded in tissue. Here's her lower left that she's now getting sensitivity to chewing, and you absolutely can see on 2D that there's something going on with number 20. And here's the limitation of 2D. So here's a periapical of 10, 11, and 12. And what do you see beside the calculus? And this is called resorption. Yep, resorption. Is it on the buccal? Is it on the lingual? Is it internal? Is it external? You have no idea. Enter cone beam. So I won't get into this heavily, but this is why I take an hour. So here's the upper tooth number 3 from the axial view or the occlusal view. We call it the axial view. And there's no MB2 canal filled here. And as I scroll further apically, here's the lesion and why she's sensitive in the upper right. The tooth was filled short, so here's your MB1 canal, here's your MB2 canal. That's how precise this imaging is. And this is from a company called Prexion. Their images are unbelievable. I mean, you can actually see the unfilled canals leading to the issue. Now you have to make the determination, what are you going to do? And it's also interesting here, just to show you, here's her buccal wall. So the buccal wall has not been perforated. Here's the coronal view looking front to back. Here's the width of her ridge. And there's the size of the lesion. There's her sinus. And now I can explain the problem. So I'm showing her all this, and she goes, where is it? I'll tell you where it is. Here's your digital scan. It's underneath your rear molar. So now I'm using my digital to explain the proximity and what's going on. Your rear molar doesn't have any function. So now, what do we want to do with this tooth? Do we want to save it? Do we not? Do we want to restore down here? Do you want to leave the area alone down here? Her lower bicuspid hurts. You can see the bone loss here. I'm going to go back. You can see the bone loss here, probably a vertical root fracture. When she loses this tooth, how are we going to explain it? Here's her resorption up here. Let's go to a better view of that upper canine. Here's the axial view. External resorption. Here's the canal. So we know the external resorption is not in the nerve. And in fact, from this view, I can tell you here's her palatal crest. When I lay a flap, I'll be able to see the resorption because here's her tissue level. It's coronal or above the bone. How can we be doing dentistry without these great tools? The endodontist reviews the scan online. She says, I can try to retreat number 3, it's guarded. Number 11, no endodontics required. My periodontist comes online. We can put implants in if she doesn't want to save number 3. What are we going to do? What's the plan with 3? What are we going to do with number 13, which is an edentulous space? What are we going to do with 20? Because we've got to take that out. Are we doing a partial? Are we making implants? What are we doing? So within minutes, I take this patient and I can drop in a couple implants on the Prexion software like any wonderful 3D software system. So I can pop in some implants, explain to her where they would go, explain to her where our bone and why we have plenty of bone. And then I bring her back in to my digital scanning, her lower arch. We're going to lose tooth number 20. This is number 3 on the other side. So if I lose this tooth, what are we going to put up here? What are we going to do to replace this tooth? Does she want a partial? Does she want implants? What kind of bone grafting am I going to decide to do? It all is based on what our future treatment plan is. So I show her, if we're going to take out this tooth, we can put one implant here and an implant on the bottom, and we can restore occlusal function because this tooth is toast. It's just hanging on. And this is the beauty. I can take digital scanning and cone beam, all the technologies today, Carry View and Spectra and 2D, and really combine them into explaining to a patient, we can place the implant here. She's looking at this as she's sitting there, understanding there's no function on the molar and we need to add function here. And this only is going to increase her treatment plan acceptance. And the finding of external resorption, what do? Do you do nothing? Do you treat? How do you do that? And so we do treat it. And as I go through all this, I couldn't imagine not having these technologies. Basically, I need to see what's going on. I need to evaluate what's going on. I need to diagnose what's going on and ultimately bring the patient back into this to discuss their options and costs and time frames. This allows them to make the right decision. Then you bring time-lapse in and all the newest things that this technology is bringing. And now they're on your dental plan. You're growing your office, creating value add, far better diagnostics for monitoring, and everything's a home run. Can you really imagine diagnosing this woman's case of tooth number 3 on 2-dimensional x-rays or her resorption? There's just no way. Can you imagine how many pathologies you're missing with 2D imaging? And does this not ultimately affect your success outcomes? And then how do you explain them to the patient? Ultimately, she wanted to save her bridge. That's what she wanted to do. She didn't want a partial, so she's opted to have implants on 13 and 20. She wanted to treat number 11 as soon as possible for her external resorption. She needed some periotherapies and some basic restorative work, all based on a good initial examination. She had to go through her costs. She looked at financing through our office and our own prevention plan and decided she'd rather save the money, not pay, and basically save the 15% or 13% in our in-office dental plan. So one leads to the other to growing your practice. So as a general dentist, you are the general. You got to review the diagnostics. It's creating the referral workflow that you don't want to do and creating how it's going to work best and creating the next steps. Her comments from the first call, she was told I would give her her options and recommendations. Give and take. Listen, learn, guide. Then she asked me, can you see my husband and daughter and her family? And that's how you grow a business on referral, not Google clicks. So I want to thank you for sharing your night tonight. I know it was more than just digital scanning, but I really wanted to show you how digital scanning has really become more a part of an integrated technology in our office, both from initial exams, recall exams, and of course, scanning for your crowns and implants and everything else. I'll take your questions, and then we'll all get ready for our Thursdays at our practice. Are there any limitations to scanning restored surfaces? And the beauty is no, you don't have to powder at all. You'll see your composites, you'll see your amalgams, Josh, you'll see your gold work, you'll see everything. No reason to powder whatsoever. The key is just getting rid of saliva. So usually when I'm scanning, I'll air dry the occlusals, you get beautiful details, and then I just wrap it over the buccal and the lingual and get full arch impressions. So no limitations on scanning restored surfaces. But I'll wait for more questions, because there's gotta be a few more. You want to egg them on, Lisa? Okay. How accepting are older patients towards digital scanning? Okay, so the first thing I can say is, oh, I love older patients. And older patients are going to trust you no matter what. So in the old days, I would take out like models and things like that, and that's how we explain things to older patients. Now I scan them, and honestly, it's all visual for them. They don't look at it as digital. They just look at that they can understand and see. And I'm telling you, you got to walk them through this. So I think it's a great tool, an absolutely great tool, Brianna, for this. Which setting do you use for your initial scan? Well, when you say which setting, I really take models. All I'm using is models. So it's a record scan. I'll do a record scan in a bite, Ken. And so my initial exam, I go to records, not restorative, nothing else. I just go to record scan. I take upper and, well, my team does this. They take an upper and lower and a bite, and then I walk in. Just had a demo on CareView. Do you think this is a must-have for a practice? So Tom, I will say this. CareView is an amazing technology for interproximal decay. You'll see far more interproximal decay on CareView in the contact zone, not in geriatrics by the gum line, in the contact zone. And I will tell you routinely, you'll be able to see E2 lesions, which are deep enamel. Then you'll see D1 lesions crossing the DEJ, and then you'll see D2. Oftentimes you see absolutely nothing on an X-ray. So we have 2 CareViews in our office. We have 9 ops. We use it on our initial exams when appropriate. In other words, if someone's full crown and bridge, we don't use CareView. But if a patient comes in and they have no lesions interproximally, it's what we use as like Spectra, everyday diagnostics, far better. And Ken, I'll just tell you this. If a patient walks into my office and they're under the age of 18, we use CareView and we don't take bite wings. And we just save the CareView because they're that much more diagnostic. Next question. How about the impression for a crown? Well, let me just say, Linlin, when I guess that's your name, about the impression for a crown. It takes me basically, and I didn't even cover it tonight because I wanted to cover so much more than just taking an impression. We do just quadrants for a single unit. By the time I pull my cord, let me just tell you how this works. If you want to be in the most efficient practice, your assistant can scan the opposing, you scan the abutment, the preparation, then the assistant can scan the quadrant and the bite. Openly, this is so much fun. I don't like my assistants to scan when I'm doing my own impressions. I just like it. It's fun. It's my only fun in the day. It's digital scanning. So I would say a quadrant, for me to take an impression of number 3, I am in and out in 2 minutes. I see exactly in the first 8 to 10 seconds if I've got my margins, and I don't have to wait for a retraction. I don't have to wait to pull anything out of the mouth. So that's what I would tell you. Typical quadrant takes me a typical, like we'll call it a triple tray. Impressing number 3, the opposing in about 3 minutes, totally done. And sometimes it can be done in less than 2 minutes. To use intraoral photos, very much since you treatment plan with scanning. Okay, so intraoral photos, a lot of times I'll use them if I'm doing cosmetic dentistry and I want to really communicate with both the patient on color and the lab. But I will tell you this, Albert, I use less intraoral photos now because I scan every patient. So the intraoral imaging is less important to me now because of digital scanning. I love my digital scanning for that. Okay, other than iTero, what other digital scanning CBC systems would you recommend? Okay, I will just tell you, I mean, obviously, look, the other player out there is 3Shape. I have not used it. I have obviously Catapult members who have, and you have to see which system is best. I would never say anything negative, and more are coming. I just love the way iTero integrates Invisalign with everything else we do because I have 2 other Invisalign providers in my practice. As far as cone beams go, cone beams have to be specific to what you're looking for. I'm a Prexion guy. It's a company that few of you have heard of. It's a growing company. I also have a Cavo Kerr system. I have 2 systems in my office. But you got to have, when you buy a CBCT system, I'm just going to tell everybody, you have to have fields of view that make sense. Don't get one with 1 field of view or 2. So I like systems with 3 or 4 fields of views so you can really customize what you're imaging. And then you also have to customize how fast the scan is. Are you doing a high density, a standard density, or what we call a rapid scan? But, you know, I'm a Prexion guy at this point, and I love the system, and the company's been amazing. Can you use your initial record scan for future Invisalign evaluation? Absolutely. Have you encountered any issues while scanning patients with a hyperactive gag reflux? Okay, I'm just going to tell you, here's the beauty of this. So let's say you're scanning and the gag reflex would be on the tongue. So what happens is I guide the scanner between the tongue as I wrap the lingual surface, Brianna, and I will tell you, if the patient gags, you take the scanner out, they swallow, cough, and you go right back to it. You just go right back to it. It's just that simple. So when I talked earlier about customized scanning, you know, if the patient's a gagger, you can say, take a deep breath, you scan the occlusal. Take a deep breath, then you scan the lingual. Take a deep breath and scan the buccal and overlap it, and you're done. So I would absolutely tell you, my gaggers love this, love it. Do you allow your careless orthodontist to ever touch your iTero? I love you, Josh. Okay. Thanks, everybody. Those are all thank yous coming in. I really appreciate you all coming. And I love doing this. Thank you.